the Stigma Reduction Campaign. My name is Dr. Bianca Loria Honer, and I'm an associate professor at Dalhousie University, Department of Psychiatry in Halifax, Canada, as well as a consultant for both the Mental Health Commission of Canada and the Pan American Health Organization. It is my great pleasure to moderate this webinar today for you. I would also like to acknowledge the team that I worked with for Understanding Stigma version 1, and I'm so excited that we are launching version 2 this year. So Dr. Andrew Vernon, he is a medical doctor, and he guided us throughout the implementation process. The following 4 are clinical psychologists who will be the tutors in Understanding Stigma version 2. Ms. Valeria Flores, she is from Peru. Ms. Javila Ho from Jamaica. Ms. Moza Hudson from Guyana, and Dr. Khadija Khan from Trinidad. We also have Dr. Asha Pemberton, who is a psychiatrist from Trinidad. They have been very supportive and excellent as tutors in version 1. So just a bit of the background. We know that mental health is important for a person's well-being, and yet there's still too many worldwide who are experiencing mental health challenges. Mental health and substance use disorders affects us all, whether it's personal, professional, socially. And Kessler, in a study that he conducted in 2012, reported that 1 in 2 people will experience a mental health disorder in their lifetime. Well, that is huge. Yet mental health related stigma is so pervasive, and some will report that it is at its highest within the healthcare setting. So it affects people from all walks of life. It creates serious barriers for help seeking for fear of prejudices and discrimination. I can remember when I first started research, people would come into my protocol, and because they were ashamed of experiencing a mental health disorder. So I had to write on their chart not to consult their family doctor, nor consult their loved ones because of the shame that they experienced. We've come a long way. However, we have a lot of work still to do. So they're unwilling to seek help for fear of what others may think, or for fear of prejudices and discriminations within the healthcare setting. So we need to begin to understand and develop strategies to understand its root cause and adopt strategies to overcome it. So for this reason, the Pan American Health Organization and Mental Health Commission of Canada collaborated to develop these stigma reduction strategies and address this challenge. So today we have an amazing panel who will speak on these 2 important initiatives. And with this, without further ado, I will introduce our first speaker. We have Dr. Claudina Catano, who is the Regional Advisor for Non-Communicable Diseases and Mental Health for PAHO WHO. She will first introduce the Understanding Stigma virtual course. I've had the pleasure to work with her since 2018. Over to you, Dr. Catano.
Thank you so much, Dr. Bianca. Is definitely, I feel like we are with family because of the years that we have been collaborating together. So I'm so glad that we can continue this collaboration, and it's a pleasure for me to be part of this launch. And as you rightly mentioned, this launch is to launch the virtual course and the stigma campaign that we have. So for this, I bring greetings from the organization, the the director for a department, who is Dr. Ansel Hennis, and greetings also from the unit chief, who is Dr. Renato Oliveira. So when we talk about stigma and discrimination, we know that the stigma and discrimination, the scars that they leave on people are very difficult and hard to heal. Sometimes when you know, why does this matter? Why stigma and discrimination? Why it is so important and what it is? We know that the stigma is a sign, is a mark that excludes person from the rest of others, and at times we may have experienced a stigma ourselves, and we may have we too that can also be guilty of stigmatizing others. And we know that the stigma itself can be more long-lasting and life-threatening than the mental health condition. Why? Because it stops people from seeking help. It stops people from people living in silence, and this has a huge impact on their well-being. And discrimination is something, is the action, is the decision that treats a person or a group that, you know, differently. Discrimination could be because of your race, your ethnicity, the color of your skin, your religion, your sex, your age, and all of those things. And here we're talking about, in the health context, we're talking about mental health disabilities. So people who are discriminated because of the fact that they may have been diagnosed with a mental disorder, and no one wants to be, this is by no means of their fault. This is by no means because this is what they want, but yet they are discriminated. So why it is important why do we have to address mental health stigma? Because as I mentioned before, it's very damaging. It can be life-threatening because people don't seek help. It can be more, you know, definitely a lot, sometimes it's much more, as I mentioned, damaging the illness itself. And so it's very important that we take the understanding of what it is that we need to do to address the stigma. We need the examples of how stigma manifests itself is sometimes by being dismissive or disregarded, or, you know, being disrespected. And people, because of having a mental health disorder, they also can be excluded from opportunities for employment, for housing, to live a healthy life, a decent life as a human, productive life, where they can be a good citizen that can provide and contribute to their society. So it is very damaging, and definitely we need to find alternatives or strategies to address stigma. But we all know that there's a lot of barriers, and all too often these barriers that exist make people become reluctant, or they cannot seek help. And so there is issues that we consider that will be like barriers, could be in terms of the inaccessibility to resources, and on affordability, when we talk about access to good quality of health services. It also could be because of the low mental health literacy, the lack of knowledge and the lack of understanding that still prevail, and all these myths that exist about mental disorders. The stigma is, as you know, becoming a stereotype, has a lot of shame, and there's huge human rights violation. So people are discriminated. There's a narrative here on that screen that you see about how the impact of a stigma, and I'm just going to be reading it. This is from our recent report, the WHO recent report on mental health. This is where we have this narrative comes from. My healing only began when I overcame the stigma and realized there's no shame in asking for help. And these narratives are not new. We always hear these things. Sometimes people take up to 5 or 10 years to seek help because of the shame that they may have, because they know what it means to open up about having a mental disorder. And there is effective intervention. I'm not going to mention everyone, but there is some intervention, not necessarily effective. We should probably say there's intervention to address them. The different intervention could be, these are the ones that we mentioned, but in terms of effective, we probably highlight contact, which is the opportunities of having people with lived experience being part of our everyday activities. Because they too have family, they too have jobs, they too have homes. So being part of being able to demonstrate that recovery exists, that recovery, they are in recovery, they can do well. So one of the effective intervention, and this is something we have learned from our partnership with the Mental Health Commission, the importance of contact, social contacts, having persons with lived experience participating in policy decisions, participating in capacity building, being part of the work that we're doing in mental health. So what are we been doing from PAHO when it comes to the response? Because we take this very serious as an organization that it dedicates, our mandate is to work with health, and in health, our mandate is a public health. So stigma and discrimination is an important component of our mental health plan of action, and even of the current mental health strategic document that is newly developed. This is a very important component. So we have partnered with the Mental Health Commission of Canada, and the reason of partnership, because of their experience of the work that they have been doing in this area, has become extremely relevant for us to be able to partner. And unfortunately, they have given us almost everything possible for us to be able to take us through this journey of bringing information, capacity building into the countries that we're working with. And here I mentioned the Caribbean, but we also have done courses with in the Spanish-speaking countries. So we started with before COVID, clearly, we started with a stigma reduction workshop in one of our Caribbean countries in Suriname. And then that led, when COVID came, so that led to start to do the first stigma reduction virtual course. And because it's a course that was developed in Canada by our colleagues, we did a pilot, and after the pilot, we launched the course, the first course, where we had over 123 primary healthcare providers registered from 16 English-speaking Caribbean. Now we have, for this course for 2022, very pleased to say that we had close to 300 persons that applied for that course. Clearly overwhelms our capacity. Thank you, about disaster that's overwhelms our capacity, because we will not be able to attend all of them, but we are very fortunate that with the tutors that were mentioned, and the facilitator from Dr. Bianca and our tutors from the Caribbean, we will be able to address, if not all, but the majority of the participants. So this is just the brochure that was prepared to promote this course. And as I mentioned, this course, it is through the virtual campus for public health. We're very pleased that we have the campus. It's free of cost. It's available to everyone. It's very dynamic. And so our participants will be able to have a better understanding of what a mental health related stigma is, what is the impact, and what they can do to reduce it. The program is very structured. As you know, it goes through 7 modules. And in one of those modules, we also include a section on one of our tools, which is the image gap. Most people are familiar with the image gap, which is the Mental Health Global Action Program for primary healthcare providers who are not specialized in mental health. So there's a component of that as part of building capacity, increasing the healthcare provider competence, because we know that there is very limited specialized human resources. So I'm going to stop here, and I thank you so much for joining us to launch this second version of the understanding stigma and strengthening the cognitive behavioral interpersonal skills. Thank you so much. Over to you, Dr. Bianca.
Thank you, Dr. Catano. That's a great overview of understanding stigma. And one of the things that practitioners mentioned in the evaluation was that people present to within the healthcare setting in a vulnerable state or in crisis. Therefore, it gives the perception that no matter what practitioners do, doesn't help. So that recurrent positive experience with the tools, the skills, the ongoing communication, it puts people in the proper light that they can, and the goal is for them to recover, and therefore provides hope, the hope required, and truly engages practitioners in their care. Thank you, Dr. Catano. Okay, our next speaker is Dr. Gabriel Listovsky, and he is the regional coordinator for the virtual campus for public health for PAHO WHO, and he will be talking about the virtual campus for public health. Over to you, Dr. Listovsky.
Thank you very much, Bianca. Buenos días para todos. I will speak
Good morning,
Spanish.
everyone.
The participant want to hear English, you can select English in the interpretation link. Muy buenos días.
A very good morning, and thank you very much for the invitation. It is a pleasure for me, and I'm very enthusiastic to be here supporting a new activity by the mental health unit in version 2.0 of this course. I was just remembering that exactly a year ago, we were launching version 1.0 of this course. In principle, at this time of the opening, I wish to congratulate every member of the team working on this course. I have now had the opportunity to visit the classroom and see some of the presentations. So first of all, I want to congratulate the entire teaching team. And also, I wish to thank the Mental Health Commission of Canada for its support for the development of this project. I will now take the liberty of spending just a minute to share my screen. Please be patient. I'm ready to share my screen now. I don't know why you can't see my PowerPoint. Give me just a second. Forgive me. Now it's working. I would just like to take a few minutes to introduce you to the virtual campus for public health and tell all of the participants in today's meeting that our main goal, our main challenge is to develop capacities and competencies within the health systems and amongst health workers in health systems. We always say that the virtual campus is not a university, it's not an academy, but it does work very actively hand in hand with all the faculty and international experts to bring knowledge to practice by linking conceptual challenges with practical challenges. The virtual campus. And in today's meeting, I was saying that we have more than 200 participants now. Certainly, some of you are have been selected to be students in this version 2.0 of the Stigma course. And for some of you probably have not yet participated in the virtual campus, we invite you to sign up and see all of the proposals there and all the offer. And I have a slide about participating in all of the activities linked to this unit and training in public health. The virtual campus is an open, interoperable platform that works cooperatively with all of the academic institutions in the region of the Americas and works actively in Spanish and English. And we're very pleased with the number of products that we've been able to offer in English, and we are actively reaching people who need this by adjusting the materials to the characteristics of each subregion. In 2014, the virtual campus had less than 62,000 people enrolled. Now we have more than 1.926 million users, and we have 4 million currently enrolled. This means that every user who visits the campus, for example, a user who was selected to participate in the Stigma course, will have the opportunity to self-enroll in other courses. The majority of our participants are health workers. They are primary healthcare professionals, and we are very enthused to see the health sciences students. Year after year, they increasingly use our virtual campus and approach content that we know are worked on with the programs and these various tests. I have a few key recommendations to participants. That is for the Stigma course students. A few comments targeting them and an invitation to everyone who is just hearing about the virtual campus for the first time today. Frequently enter the campus. Those who are following the Stigma course at this launching today. And also you should be engaged in the forums and those exchanges, have conversations with your colleagues, take advantage of the experience the tutors have to share with you. And with this course and everyone who works with the mental health unit, there is a chance to link to various health workers and various colleagues. We get linked to experts, people who have expertise, and we can have exchanges about the experience in our countries and put that knowledge into practice. And we can analyze this and continuously apply it to our practice. We invite our colleagues in the course to take advantage of this, discuss, learn, work, and discuss with your tutors and share experiences. Physically, we are far away, but we are very close to you through the virtual campus. This is also an invitation to all colleagues participating in today's meeting. When colleagues conclude the course, when they reach the end of the course and have carried out all of the activities, they receive a certificate similar to what we awarded in 2021 with the signature of our director. So we hope to see all of you at the end of the course, and we want to hear about your experiences and your recommendations for future editions of the course, like we're doing right now with version 2.0. We took advantage of what we learned in the last version, and we always make available questions about the virtual campus for anybody who needs technical support. Now, for all colleagues participating in today's meeting who are not particularly students enrolled in the Stigma course, I've placed here a sampling of some of the mental health courses available that are applicable, since today we're talking about the English language launching of the Stigma course. So I've only put English courses here, but I invite everyone at the meeting to visit the virtual campus because each one of these products also has a version in Spanish for whoever would like to follow it in Spanish. These are self-learning courses. Everyone can enroll independently, collect the materials, and particularly study a given module. And then once you meet all of the requirements and come to the end of the course, you get a certificate from the virtual campus. I again congratulate the mental health unit for everything it has developed, for the progress you have made, and for bringing knowledge to practice through this virtual platform. We know that the virtual campus products are now first-rate quality and bring knowledge to each of the health services of our region. So for our colleagues who are just learning about the campus for the first time today, this is the link for you to take a look at the campus, become familiar with it, and self-enroll in various courses. Once again, congratulations. I wish you continued success. Great job on the course. Thank you very much. Back over to you, Bianca.
Thank you, Dr. Dostovsky, for this great presentation on the virtual campus. And I can attest that both tutors and participants reported that the platform was extremely valuable to help them succeed. Not only the communication platforms, but the format, the model, the way it was created. So we really appreciate having worked with your office. Okay, now on to our third speaker, Mr. Mike Petras. He is the Director of Mental Health First Aid and Opening Minds Canada of the Mental Health Commission of Canada. So I have worked with Mike Petras for 9 years, and the Opening Minds branch of the commission has done tremendous work in stigma reduction. So these are just a drop in the bucket of all of the great things that Mr. Petras has done or facilitated. So with that, I give the floor to you, Mike. If you can go ahead.
Unmute here first. Thank you very much, Bianca, for those very kind words. Good morning, everyone. Pleasure to be with you this morning, representing the Mental Health Commission of Canada to mark the launch of Understanding Stigma version 2. I just want to congratulate everyone involved as well in this important collaboration. PAHO, the PAHO Virtual Campus, Dr. Loria Horner, and those from my team with the MHCC as well. And I want to commend them for the hard work and dedication to bring this all together and actually make it happen. As you're aware, the curriculum is a combination of 2 complementary anti-stigma based programs used successfully in Canada, in Suriname, in an in-person version of the course, and as well in the virtual campus in an online version last year. The programs were evaluated, the program in Suriname, the curriculum, as well as the online version last year. And in both instances, they tested very well at reducing stigma and providing useful skills. The program grew out of work done by members of the Opening Minds team of the Mental Health Commission. Opening Minds is the Commission's anti-stigma initiative, which was launched back in 2009. And it's the largest systematic effort undertaken in Canadian history to reduce the stigma associated with mental illness. Now, as we've heard from our speakers earlier, stigma is a major barrier. In my country alone, we know that 2/3 of people won't seek help for their mental illness. It's seen as a major impediment. And as we heard, some people report that the stigma that they experience is often worse than the illness itself. Now, here's an interesting comparison. If I was out at lunchtime today and happened to trip and sprain my ankle and it hurt badly, I'd go see my family doctor, go to the emergency department. But just imagine these statistics. So somebody living with a mood disorder may wait 6 to 8 years before seeking treatment. And with anxiety disorder, the research shows 9 to 23 years before they'll seek help. So you can imagine if I waited that long, if I had a serious break, the complications that would set in, and how my mobility would be affected if I waited that long to seek treatment. So why are people delaying seeking treatment? As we heard, they don't want to be labeled. There's so many labels associated, negative labels associated with mental illness and mental health problems. People don't want to be seen as weak, as lazy, or in some other instances, people use terms like crazy and dangerous. And then there is, the effect that self-stigma has. People are ashamed, as we heard, and are reluctant to seek help. So we need to overcome the stigma barrier if we're really going to have an impact and be effective. So back in 2009, where to start? Such a big problem. What we decided to do was a little bit different than the norm. So rather than undertaking a social marketing campaign, we had limited resources. So in terms of spending it on TV commercials or billboards or things of that nature, we decided instead to take a targeted and strategic approach. And what I mean by that is by focusing on groups where we thought we would have the most impact. And one of those groups was healthcare providers, because some of the worst stigmatization, believe it or not, and it surprised me when I first learned of this, takes place on the front lines of the healthcare system. So during our research in the project and looking at healthcare providers, we found that healthcare providers were generally pessimistic about recovery, that they don't believe what they do really makes a difference. And that's understandable because they generally see patients who are ill and in distress and not in recovery. While people don't seek help when they're feeling well. So what we found was that generally healthcare providers lack the skills needed. And that lack of skills leads to a lack of confidence when providing appropriate treatment. And oftentimes too, there was a lack of awareness of personal prejudices. Healthcare providers seeing the illness and not the person. So where to start again, as I mentioned, we were considering starting from scratch, developing our own programs. That was really quite exciting. And then we sort of paused for a minute and decided that why reinvent the wheel? Let's put out a call and see what work is being done across Canada in this particular instance, and see if there were effective programs already out there. We quite honestly didn't expect to see much in the way of results. But were we shocked? We received well over 140 proposals. Identification of programs were out there. And that really posed a challenge in itself. So we pulled together a panel of national and international experts to sort of help us sort through who we should work with first in terms of identifying the most effective and promising programs that were out there. And one of the key factors that they asked us to focus on, which was a promising practice at the time, but I would suggest now it's a best practice, and you've heard about it, contact-based education. So that's using videos and personal stories and testimonials from people with lived experience who share their stories and talk about the stigma that they experience and what it was like to live with a mental illness, but more importantly, what was that catalyst that got them to seek help and how have their lives changed since they got help. So I narrowed down the group of programs that we were working with to about 25 initially, and we wanted to look at those programs that were effective and identify what were those active ingredients and what were the gaps that needed to be addressed. And in order to do that, we had to develop new evaluation tools because they didn't previously exist to measure those kind of things. The net result, evidence-based programs that are able to deliver positive outcomes. And the Commission continues to promote and create courses and toolkits and assist those individuals and countries who are interested in reducing stigma. So that is the genesis of understanding stigma and cognitive behavioral interpersonal skills. And what Bianca was able to do was combine these two programs, both in an in-person version and in the hybrid version, the online version as well. So even though the general feeling out there in some countries is that a lot has been done to reduce stigma and progress has been made, there's still a lot of work that needs to be done in this area. Back in 2008, the World Health Organization predicted that major depressive disorder would become the leading cause of disability by 2030. Well, that became a reality in 2017. And when you look at depression alone, it affects more than 280 million people globally. And as it was mentioned a bit earlier, 1 in 2 people in a lifetime are likely to experience a mental illness. So it's so common, and yet we don't give it the attention and focus that's needed. And mental health has never been in the spotlight as it is right now. The anxiety and isolation created by the pandemic has really had a major effect on people's mental health and wellness. And more people are coming forward to seek help. This is our opportunity to make a difference in breaking down the stigma barrier and provide better care through programs such as Understanding Stigma and CBIZ. International collaborations like this one will make a real difference in changing attitudes about mental health problems and mental illness and create a more supportive environment. And participants such as yourselves, the people that are going to be taking the course, are to be commended. The knowledge and skills that they acquire through this training will make a real difference for those people needing help. And as I mentioned before, create a more supportive and positive environment. And just before I leave you or close, I would really encourage you to reach out to Dr. Catano and Dr. Loria Horner to let you know when the research will be published in the BMC Medicine Journal. I've had the good fortune to see an advanced copy of the results, and very, very impressive. And I'm sure you'll enjoy reading that research as well. So thank you for your time and your interest.
Thank you very much, Mr. Petras, and especially for your really good insight on stigma and how it impacts people with lived experience. It is always astonishing how we talk about stigma for all these years, and yet we try to implement strategies, and sometimes we just don't get the impact that we want. So the fact that we reuse, or the Commission reuses program, evaluates them, tweaks them, and then upscales the programs, I believe that is quite a very productive strategy. Thank you very much for that. Our next speaker is Dr. Jose Luis Vasquez, and I had the pleasure to meet Dr. Vasquez last year, and his title is a treatment specialist, Demand Reduction Unit, Inter-American Drug Abuse Control Commission, CSAD, and the CSAD stands for the Spanish acronym. So over to you, Dr. Vasquez.
Thank you very much, Dr. Loria Horner. Good morning, everyone. Thank you for the opportunity to address you today. Special thanks to Dr. Claudina Catano, PAHO's Regional Advisor on Mental Health and Substance Use, who has been our main point of contact regarding the stigma projects. Thanks also to PAHO's staff, Dr. Andrew Vernon and Mrs. Marta Cuev, who helped to put everything together for today's session. I am Jose Luis Vasquez Martinez, a specialist in the Demand Reduction Unit in the Executive Secretary of the Inter-American Drug Abuse Control Commission, known by its Spanish language acronym, CSAD, which is part of the Organization of American States, OAS. I work under the leadership of Jimena Kalowski, Chief of the Demand Reduction Unit, and Ambassador Adam Nam, CSAD's Executive Secretary. CSAD is the OAS consultative and advisory body on the drug issue. It serves as a forum for OAS member states to discuss and find solutions to the world drug problem, and provides them technical assistance to increase their capacity to counter it. Since its establishment in 1986, CSAD and its Executive Secretariat have responded to the ever-changing drug control challenges, expanding its efforts to promote regional cooperation and coordination with and among its member states. The world drug problem constitutes a global challenge that disturbs public health, security, human rights, the environment, and well-being. It also undermines sustainable development, justice systems, political and economic stability, and democratic institutions representing a threat to security, democracy, good governance, and the rule of law. In the Americas, the drug problem is an increasingly complex, dynamic, and multicultural phenomenon with adverse effects on health, social cohesion, citizen security, the integrity of democratic institutions, development, and economic activities in the countries of the region, with political, economic, social, and environmental costs. Responding to this problem requires a comprehensive, balanced, multidisciplinary, and evidence-based approach in full respect of human rights and fundamental freedoms under the principle of common and shared responsibility, which considers the causes of the problem. Following these guidelines, countries of the Americas agreed on the OAS 2020 Hemispheric Drug Strategy and its corresponding plan of action to address this borderless phenomenon, using innovative strategies, prioritizing the pressing issues that require more attention. These political documents highlight the need to address the stigma, exclusion, and marginalization associated with substance use disorders, which deter individuals from seeking, accessing, and completing demand reduction services. Stigma can occur when society identifies a specific characteristic or a chronic illness like substance use disorder as indicators of a tarnished character, or sees persons with these conditions as inferior to or worse than others. Currently, people with substance use disorders face similar discriminatory attitudes as those with depression encountered 20 years ago in a context lacking details of the neurobiological mechanisms implicated. Although people accept brain chemical imbalance can produce depression, the explanations for substance use disorders come from different standpoints, often involving subjective perspectives not informed by evidence. Even though international consensus recommends communicating substance use risks and treatment benefits to people with substance use disorders in a non-judgmental, respectful, non-stigmatizing, empathic manner, sensitive to age, culture, and language differences, some experience mistreatment, discouraging them from talking about their problems and requesting help. Unfortunately, this happens even in clinical settings where people should access evidence-based, high-quality services. Motivated by this, CCAT's Demand Reduction Unit requested the help of Dr. Jasmine Mora, a researcher at Mexico's National Institute of Psychiatry, to offer the online course, Stigma and Mental Health, Challenges to Building Quality Care in 2021 for Hispanic American countries. Dr. Mora's team has delivered this online training since 2018 for Mexican professionals, attaining promising results in healthcare providers, like being more willing to help, acknowledging their stigmatizing attitudes, and identifying actions to deal with those. The outcome of the 55 participants who successfully finished the course, the 2021 course, shows that raising awareness and training are essential to tackle the stigma associated with the broad range of mental health problems, emphasizing substance use disorders. With activities like the updated version of the Understanding Stigma course and the launch of the Mental Health Stigma Reduction Campaign, we are committed to implementing strategies and actions in countries of the hemisphere to address the difficulties and consequences that stigma imposes on society. At CCAD, we are grateful for the participation in today's session, where we will listen from the experts about the foundation of stigma, what we know about its current situation in the Americas, and good practices to tackle this issue and its consequences on the population. Unquestionably, your participation in the activities launched today under the guidance of experts like Michael Pietrus and Dr. Bianca Laurier-Horner from Canada's Mental Health Commission will be instrumental in helping address the world drug problem integrally by putting individuals at the core of the public policies and in fully respect of human rights. Thank you very much, and back to you, Dr. Laurier-Horner.
Thank you, Dr. Luis Vasquez. This work is so relevant, in particular since COVID, where substance use, I believe, has doubled or tripled. Many still think that when somebody experiences a substance use problem, that they are responsible for their disorder. So the stigma is very prevalent and we need to change that. Thank you very much. Our next speaker is Miss Maria O'Brien Devine, Miss Maria Davina O'Brien, and she's the director of MindWise Project. She shared a few months ago an inspiring personal story with me, and I believe that this will move you as well. The floor is over to you, Ms. O'Brien.
Thank you so much, Bianca, and thank you for your help in helping me craft this story to share today, as well as thank you to Dr. Catano for giving me the opportunity to support. This is very exciting work and very important work. Good morning to all of the healers and those who help them in this room. Thank you for the privilege of speaking today on my lived experience with stigma as a Caribbean woman, survivor, and mental health activist. My name is Maria Davina O'Brien. I am the daughter of a first-generation Chinese woman and a Vietnam War veteran of mixed Indian descent. Today, I would like to share my intention to perhaps help in the healing of others through my story. In the beginning, my home was not a safe place. It was a war zone. Typical to many veteran homes, my father struggled with his own PTSD, substance abuse and addiction, and anger management issues. Before I was born and before he got sober, my father would boogie trap our house to prevent enemies from breaking in while he was asleep. Living with this violence and fear and growing up in this environment, the beginnings of my anxiety started to show. I had several physical signs of trauma and abuse. However, in our community, the way this was handled was with shame and secrecy, not to mention leaning on God to save us from the devil in my father. After terrible nights of screaming and violence, in the morning, tea would be made and the events of the past night would be wiped clean. But I think I speak for all children in violent homes that we never truly believe this illusion. It is a dream that never lasts very long. I would like to mention here that the stigma around the violence and suffering of domestic violence was only enhanced by the entire community joining in the activity of burying the pain. Everyone would know what took place the night before, and yet they would avoid checking in or intervening. I know now that there are many reasons why a bystander would not intervene, but as a child, it just feels like that is the way we're expected to handle it, bury it, and pretend. This led to a belief that what was happening to me was normal, accepted, and no big deal. There is nothing to see here, nothing to talk about, nothing to fix or heal. Of course, these patterns never end without something truly horrific happening. At the dawn of my adulthood, at 19 years old, one final incident of violence took place in my family home, where my father attempted to strangle me to death in a fit of rage. I did escape and moved to a secret location, where I then hid from my father for several months before leaving the country to move to the United States, which was quickly organized by my family to keep me safe. It was this incident my treatment would uncover that truly changed everything for me. It is where I lost all trust in my family, my ability to be safe, and I felt as if I was completely on my own. I never thought to myself, experiencing these storms, that something could be unbalanced with my father. Even knowing about his history with drugs, it never occurred to me that he could be dealing with an internal struggle that led to his violent outbursts and attacks. We did not think of our reality as a consequence of unmet mental health needs. Similarly, I never thought about how it was affecting me as a child, except that the fear was unbearable, and I fought very hard to stop being afraid. We never saw ourselves as persons who needed mental health care or treatment. This was never a discussion that ever took place in my family, nor within our community. Therapy was for mad people on the street, or people who could not take care of themselves, or for persons who were too weak to beat back the pain and succeed. This damaging perception about who needs mental health treatment clouded my judgment about my own needs well into my 20s. It is a very limiting belief that prevented me from seeing myself as someone who had been hurt or someone who was in pain. After the attempt on my life by my father, I moved out on my own, then started the nights where I could not sleep. My insomnia was intolerable, so I filled my nights with friends and parties and with noise. And with that noise came the substances. My drugs of choice were alcohol and work, two terrible addictions that worked hand in hand and fed each other. I was what is popularly framed as a highly functioning alcoholic and workaholic. It is also funny how seeking pain treatment through pills and drugs and substances was so accepted. We were just coping after all. This highly functioning relationship between alcohol and work, my trauma and my pain, took me straight through college, through my first job as a director, right up until the moment in 2011, when I lost someone to suicide in my apartment, being the one who discovered his body after he jumped out of our 8th floor window in Baltimore City. Michael was my friend, my recent partner, who was living with me at the time of his suicide. He had a history of substance abuse and suicide attempts, but I did not know this at the time. He was also on antidepressants, which I didn't understand and whose seriousness I did not grasp until reading his autopsy. His suicide and the trauma of discovering his body and all that came afterwards unraveled me. It released all the pain and trauma I had been hiding and burying my entire life. I became unable to function. This was the very first time in my life that I could not work, noting that I started working at the early age of 14. I was forced to take a month's sick leave, and I was supposed to seek treatment with a severe PTSD diagnosis from Johns Hopkins Medical Center. I did not seek the treatment as advised at this point, but I did dive into learning. I had never thought about suicide before this happened. In passionate research, I discovered how prevalent suicide was. It was clear to me that there was a lack of resources and culture that was compassionate towards those with suicidal ideation. They were seen as weak or as lost to their problems or afflictions. They were not seen as humans who were overwhelmed by their pain, with too few effective coping resources or skills. It is true that perhaps I would have seen them this way too, if I had not known Michael. Michael was a truly beautiful and kind person who was loved by everyone in the city. He showed up for his friends and his family and tried his best to hide his negative coping mechanisms from them, to hide his pain. From before the suicidal, something I would later struggle with myself, the worry others feel can be overbearing. So we lie a lot, we pretend a lot to allow those we love and those who love us to move through their life without worry. Also, the stigma associated with suicide is some of the most powerful stigma I have come across. A person who reveals this about themselves, as I just have, is labeled as unstable or not to be trusted with their own welfare. We do not take their opinions, their choices seriously anymore or with respect. But it is those very same feelings and opinions and choices that could lead us to discovering how to truly help the suicidal way past the moment of crisis. Seeking greater understanding about the suicidal led me to my own understanding of my own trauma and what trauma was. I watched videos, documentaries, read articles and books. I educated myself, probably also in an attempt to understand myself and what was happening to me. Too many years later, a flight back to Trinidad and many jobs and home changes, I finally sought out therapy. This came from my understanding that I was traumatized by my childhood and by what had happened with Michael, and that this trauma was not just going to go away, no matter how much I learned on my own. I needed professional help. As a very talkative and self-informed person, I approached therapy with total openness. I told my therapist everything. And of course, my everything was daunting from a treatment perspective. It was always a discussion at the start, which condition or issue would be treated first. Sometimes it was the addiction or the violence that I had lived through, and other times it was the suicidal ideation. I found both of these approaches separately to be unsuccessful and full of worry versus healing. One of my first experiences was with someone who was said to be one of the top psychiatrists in the country. To address the immediate fear of me taking my own life, he put me on medication after a single visit. I understand from others that this can be very common, which is worrying. I also understand that there are those who need medication in order to cope and have regular lives. However, to me, this put me in a box right away. I became a girl who needed medication to be normal. But the medication did not make me normal. It made me erratic and gave me even less understanding about what I was going through. I chose to stop it right away after several episodes and meltdowns in just 1 week. This led to a strong feeling of distrust in mental health professionals. But despite this mistrust, as a person struggling with PTSD, it was not an option for me to continue to try fixing it myself. What finally worked for me was finding help with a company that dealt with a lot of addiction and violence survivors. Within this place full of addicts and survivors, I found they had a deep respect for the struggle I was experiencing and the reality faced by those trying to master their minds and their weaknesses. It was here that I felt the least judged and the most understood. Also, because there were several support groups and frequent meetings where we shared and talked about our feelings and our experiences. For the very first time in my life, I was surrounded by persons who were all trying to heal. It was this bold environment in which I discovered and faced my trauma, and I committed completely to my healing, taking time away from work, relationships, and anything that would cause stress during this time of treatment. My trauma therapist was amazing. She saw me, and that helped me see myself. I can happily say now, after this and additional therapies and coping strategies such as mindfulness, meditation, and building a positive community of support around myself, I know how to manage my trauma and the unexpected, of which there is a lot, including my cancer diagnosis, recently losing my mother, and not to mention the COVID-19 pandemic. I now see any challenge as an opportunity to learn something about myself, to have deeper connections with those I love, and to discover truths that might help someone else who might be dealing with the same thing. I think it is important as a person successful in her recovery to share my view of one of the most dangerous stigmas for our Caribbean community, and that is the stigma of being labeled an addict. It is my understanding from my work with young people and with the community that addiction is too seldom discussed and too often colored by morality and fear. There are so many people I have met in my journey who are addicted to substances, toxic relationships, violence, cigarettes, food, work, social media, and screens of all kinds, who do not know their why. And that could be because we are not asking them. No one teaches you that the crack addict or alcoholic is filling an unmet mental health need with their addiction. For the PTSD patient and survivors of violence, addictions can bring comfort in a world where our reality can feel unsafe all of the time. Finding a safe sensation in food, drugs, 48 hours of Netflix, or the social media likes on our phone, that is a real connection that should be examined. And you cannot take away something that is filling a deep and urgent need without providing resources and knowledge on how to live life more skillfully. It is this stigma that leads me to share my story as a person in recovery, because I think too often it is hidden, and it could be a societal secret that leads to the loss of many lives if it stays a secret. The addict is not someone who is trying to die or hurt themselves. In fact, from my personal perspective, I might say addiction might be a symptom of someone desperately trying to live in the face of great pain. As a person who continues to live and cope with PTSD, I face many dark sides each day. Anxiety, fear, self-doubt, a feeling of being threatened or unsafe, despite the truth of having much support and kindness in my life. PTSD and anxiety, to me, I started to see like other voices in my head, very loud voices. An episode or anxiety attack could lead to paralysis and an inability to move from one spot. It could lead to harmful choices like not going to work or not completing tasks important to my welfare. For instance, not going to the hospital for my cancer treatment. I faced a lot of stigma around my PTSD, with my mental health coming to the forefront of my life. Others did not always understand what was happening to me, and I did not know then how to explain to them effectively my experience. Especially at work, now having experienced both having a mental health issue and a chronic illness, I can easily say there's a great deal less understanding and compassion for mental health crisis, even though I might testify the two are deeply connected. It was only when, after therapy, I learned how to advocate for myself in the workplace that the HR department started to look into PTSD as a condition and started to understand my needs better. We found a happy medium, which involved a lot of transparency, where through healthier communication and effective information and the help of doctors and therapists to document my experience, I can say that my workplace is now healthier for me, and I find great compassion and support, even if the issue is simply being overstressed and needing time to heal. Of course, being a cancer patient has aided this experience. I do believe many who do not have a chronic illness to add to their claims will still face great difficulty just to get time off to rest with no physical disorder on the table. Learning how to tell my story and explain my mental health needs is the most powerful and helpful thing that has come out of all my treatment and healing. Understanding how to address concerns about my capacity and my ability to make decisions, meanwhile, finding ways to connect my experience to others has been priceless. Self-advocacy is a critical skill I think every person struggling with their mental health, grief and loss, violence and suicidal ideation should develop. The ability to express ourselves and share our feelings is paramount to others knowing how to help us or how to support us in getting what we need in that moment. It is also worthwhile here to say that learning how to cope after decades of not coping healthily, existing in toxic systems and violent environments, and continuing to be bombarded by the global and country-level crises that face our world today is not easy. It can even seem impossible. Learning how to forgive myself for not being perfect or not being perfectly healed has been a true gift that keeps on giving. Having healing in my life is not a one-shot solution for my trauma. I know this. The pandemic, my cancer diagnosis, and losing my mother were these huge events that could have threatened my ability to stay on track with my healing. But instead, I have found great discovery about myself in those moments of intense pain and isolation. I became more intimate with my needs and what my body, spirit, and mind were asking me for. Sometimes they asked me for nourishment, sometimes for peace, sometimes for community and connection, sometimes for nature. Learning how to listen to my inner world and put it above what I am processing from the outside world has probably saved my life multiple times. In the face of hopelessness, this knowledge of how to ground oneself, to be mindful of one's needs, and also to know when to include a mental health professional for guidance and healing, there's great hope. I do believe that by frequently challenging the stigma in our community, excuse me, that is an obstacle to so much radical healing, is a hobby we must all invest in. It is okay to not be okay. We can defeat the darkness with tools, resources, and skills, and life does get better. Thank you, everyone, for letting me share my story today.
Miss Davina O'Brien, my goodness. I think I speak for everyone. Would like to express my gratitude for your courage in sharing your story. It is very powerful, and I believe that many will relate to your struggles, or at least understand that mental health struggles can be overcome and the importance to seek help. So your message of hope for recovery certainly hit home, certainly did with me, and will help many. Thank you so much for that. With this, I will again introduce our next speaker, who is Dr. Claudina Catano. And this time she will talk about the Mental Health Stigma Reduction Campaign. Over to you, Dr. Catano.
Oh, thank you so much. And I join you to congratulate Miss Maria for such a powerful testimony, so personal, so real, so raw. I think we are so grateful and to you for your courage. You know, people like you make my life and my work really worth it. And if we could, I'm really grateful and appreciative of the, you know, the braveness and the fact that you can share with us so intimate moments that your journey to recovery. And I'm sure you have touched many, many lives, and you will continue doing that. So please continue through that journey. And I think this is what makes us want to continue actually doing this work that we're doing. The launching of the Stigma campaign is, you know, because of the work that people like you are doing to make mental health matter. So this is a great opportunity for us from PAHO to launch this. It's a soft launch of the Mental Health Stigma Reduction Campaign. You'll be able to find that, we'll put a link there for the campaign. It's in our website right now. And it is do your share to support mental health. There's no reason for people to lose a life. There's no reason for people to not to seek for care if there is if we can be, you know, doing this conversation and having people talking about the importance of mental health. You heard it very clearly that if we do not work with healthcare providers who are supposed to be there to provide care, and many times, as it was said before by speakers prior before me, that if healthcare providers have all this stigma because they see people in their distress, they see them very sick, so it becomes difficult for them to understand that recovery exists. So the target audience for reduction campaign is healthcare, but we also want to target teenagers. We want to and adolescents and youth. We want to target people who are working, healthcare, not only healthcare workers, but people at work, the entire community in terms of talking about mental health, talking about you know, about the stigma, and hopefully reducing the discrimination that exists. So our campaign will be on social media, Facebook, Instagram, and Twitter. Please make sure that you tweet about this to do your share. to share conversation, share support, encourage people to seek help. I want to stop here by encouraging you to connect, to visit our website and be able to get information on this campaign. And I want to stop with inviting you that it's this time to do your share to support mental health. I definitely thank all the colleagues who have joined us for this launch and who will continue to stay with us, and because this can only be done with your participation, with your commitment, with your dedication to do your share to support mental health. Thank you. Over to you, Dr. Bianca.
My apologies, I was muted. Thank you very much for detailing or providing this overview on the stigma reduction campaign, Dr. Catano. I sense that this campaign will be a great success with this collaboration between PAHO and the Mental Health Commission of Canada, as always. And I can't wait to see it launched, basically. I believe it's in October or October 10th that it will be launched.
Yes.
Very good. So with this, I will move on to our last speaker who will provide the closing remarks, Dr. Fernanda Lanzagorta, and she is the international consultant on health promotion for PAHO and WHO. Over to you.
Muchas gracias, Bianca. Y bueno, para cerrar este webinar, primero agradecer.
Thank you, Bianca. To close this webinar, first of all, I would like to congratulate everyone on Dr. Claudia Catano's team, and also thank you very much for giving us version 2.0 of the course, which is on the virtual campus. And I would also like to invite everyone to the week on well-being from the 10th to the 16th of September this year. And here the focus is on promoting health, including mental health, and the well-being of everyone who lives in a neighborhood, and to strengthen the role we all have in terms of promoting the health of those whom we live with day to day. So I would ask you please to keep track of the events that are taking place from the 10th to the 16th of September. We will launch an event on September 12th. And then we would invite all of the panelists to thank Maria for her testimony, for sharing her history. And that is it. Thank you, Bianca.
You're very welcome. And thank you for the closing remarks, Dr. Lanzagorta. So first, I would like to thank the attendees for your participation and attention. Also, I would like to thank the panelists for your great presentations. And with this, I wish you a great rest of the summer, everyone. We will conclude this webinar and hopefully we can collaborate or meet in the future. Thank you very much.
Thank you so much, Bianca. We'll take a picture with the group and the tutors. I think some of them are with us. They can join us. This is something very sweet, very quick. Thank you. If you open your camera. Thanks, Valeria. Thanks, I think Mosa is with us. I don't know who else is with us. So
we also have the Davina and
okay. Please, if you can open your camera, then we can take a quick picture with the group. This was fantastic. Miss Maria, of course, you were, the sharing on the cake. You did such a great job. Thank you for staying with us. Can we take the picture now? Mosa, I don't know if Mosa and the other colleagues can you see them? Andrew?
no.
No?
Mm-hmm.
Okay, so Valeria
is still here, but I'm not.
Davina, okay.
The others, Khadijah, no. So,
okay. So with the ones that we have, we can just take a quick picture, please.
Okay, so we'll take the picture, a photo at the end of 3. 1, 2, 3. 1. Hi guys, thank you for joining. Take a picture after 1, 2, 3. And one more. 1, 2, 3. Thank you.
Thank you. So maybe just a quick announcement that we'll be able to share. There's a certificate for people who stayed for more than 50 minutes connected. And then I think our colleague Jose Luis is tweeting about this event. So thank you so much, Jose Luis. We are so happy to have you. Thanks, Maria. Thanks, Bianca. Thanks a lot to all the tutors. Thanks, Andrew, for all your work. And to the people who are doing the translation, we also appreciate your support. Thank you so much. Anita, Marta, Jesse, your work is definitely very important to be able to make sure that we conclude this event. Excellent. Have a good morning, everyone. See you soon. Thank you.
Bye.
Bye.